Thank you, Rohan. I really would like to thank all of you, Rohan, Pooja, Anshika, um, Dr. Balakrishnan, I don't know your name, but all of you, I think Nikhil. So wonderful what you are taking, what you are doing as an initiative. And I'm really very happy to be a part of this wonderful seminar that you have organized at the Youth Wing of IIRSI. So I would be talking about why SMILE. And this is for people who don't know what SMILE is doing in an eye. Um, as you all know, eyes are the ones which smile the most. And a real smile comes from the eyes and not just your mouth. And so it is very important to know about this new blue-eyed boy, which is there in refractive surgery. And the younger people, especially, you should know how to expand your field of refractive surgery by adding this new procedure, which has its own advantages. I am a consultant to Carl Zeiss Meditech, and I had this opportunity to help in the development of this particular procedure. So what is SMILE? SMILE is small incision lenticular extraction. It's a new paradigm for performing refractive surgery. What it involves is cutting out a lenticule within the corneal stroma using a femtosecond laser and then subsequently removing it from the cornea using a small incision. The dimensions and the shape of the lenticule confirm to the refractive error to be corrected. So if I were to describe the SMILE procedure, I'll just show you a small video. This particular procedure is done with a femtosecond laser. Right now, only one company has the market of SMILE, but I'm sure that soon other laser companies will also come up with SMILE-like procedures. Here, what we do is, this is creating the posterior part of the lenticule, followed by a side cut. This is followed by an anterior pass of the femtosecond laser, which is separated from the posterior part by the amount of refractive error that you need to correct. And this ends in a small incision. So it basically involves 4 passes of the femtosecond laser, 2 in the planes and 1 vertically to cut the lenticule borders and 1 ending as a small incision. So total 4 incisions, 4 passes of femtosecond laser. Then you can open this small incision, approach the anterior part of the lenticule, which separates it from the overlying stroma. And you can see how nicely you can separate it. This is followed by the posterior part of the lenticule being separated from the underlying stromal bed. I'm purposely showing you a very old video just to stress that the separation is and always have been quite easy. Today, it's even more easy because we know the optimum parameters for the laser energy, which would help you to not just get a quick vision recovery, but also a very smooth procedure getting done. And once you have both the surfaces separated, you can simply grasp this particular lenticule just at the edge of the incision and remove it from there, followed by a wash on the surface and also a gentle stroking of the anterior surface, which allows a quick recovery the next day. Most times you don't need to go in the interface and wash it, but this ironing is important, leaving the cornea smiling back at you. And it was in 2006 that Professor Secundo and Bloom performed the first 250 eyes in their respective clinics. And they showed that the procedure was feasible, was accurate, but the visual recovery was too slow to compete with LASIK. We at the Center for Sight New Vision Laser Center, Vadodara, started this study in August 2008. And so far, we have, this is a little old figure because it's been 13 years now and the numbers are many more. So if you look at the timeline, this is how it went. So in the 2010, the first commercial sales took place. By 2018, more than 1 million procedures were done. And in 2016, the US FDA approval also went through. The remarkable aspects of SMILE are the predictability, accuracy, and stability of the treatment, which has changed only a little since our very first study, even though many aspects of treatment has changed. Now we have much better energy and spot parameters. There is a different scanning pattern which was suggested by us, because when we started doing it was a reverse of what it happens today, and that was the cause for a delayed visual recovery which could then be solved. A higher frequency of lasers meant that there were no accumulation of bubbles and therefore a quicker visual recovery because there was no distortion of tissue. And today we have better surgical techniques, better instruments, and you would find that more than 98% of all eyes that you treat are within plus or minus 0.5 diopters of the intended correction, which is remarkable because that's what you want after a refractive surgery. And this is not just us who are saying that. There are a number of studies done all across the world. One of the studies done by Kemaya et al. Showed that 100% of the eyes were within plus or minus 0.5 diopters at 6 months. We ourselves had 95% of our eyes within plus or minus 0.5 diopters at 6 months. And these were the first few eyes done in the world without any nomogram adjustment. And we were using at that time the slower lasers which were available at 200 kilohertz, but with a new scanning pattern. At Denmark, they were doing mostly high myopia at that time, and they also showed of the eyes within plus or minus 1 diopter at 3 months. And why is it so? It is because corneal reshaping, when you do a procedure like SMILE, is happening without the help of an excimer laser. So you're using only a femtosecond laser and no excimer laser. Excimer laser has its own limitations because it works by a principle of photoablation. And you know that photoablation rate can increase linearly with fluence beyond a certain threshold. This results in a scatter, especially for treatment of high myopia. The photoablation rate also depends a lot on the depth of ablation that you're doing. It depends on the corneal hydration, the humidity, the organic vapors in the environment, and so on and so forth. What happens in SMILE is that only a femtosecond laser is used, which uses cutting instead of ablation, which is a binary process instead of a linear one. So either it cuts or it doesn't cut. There is no little cut or no cut. And much less influence on any external factors, which also means that you have a more accurate results. How about inflammation? Since you are making 2 passes of the femtosecond laser, does it cause more inflammation? It was found that total amount of energy input into the eye with SMILE is even less than with femto-LASIK, which results in less inflammation and a very high stability of treatment. And there was a very interesting study done at Singapore, where they showed that when you do a SMILE procedure as against a LASIK procedure, whatever depth you are working on at, so whatever number you are treating, it's going to have the same amount of energy incident into the cornea. So whether you are treating 3 diopters or whether you are treating 9, unlike in an excimer laser where you would have much more energy input in a 9 diopter case to be treated than a 3 diopter case. Here, because you are making only 2 passes and a side cut, the energy incident is the same. This also results in a very high safety margin. We compared the results of in 25 patients in contralateral eyes, where we did one eye SMILE, the other eye femto-LASIK, keeping all the parameters the same, and we found that the SMILE eyes scored much higher as compared to the femto-LASIK eye in terms of the safety, even over a period of 1 year. About the stability of refraction, we found a statistically significant difference when we were treating these high myopes as compared to when you're using femto-LASIK compared to SMILE. And as you can see here, the mean for femto-LASIK and SMILE were the same because you were treating the same patient. The range was from -8 to -10 diopters. And while femto-LASIK at 1 week showed an average, the mean refraction of plus 0.11, at 9 months, it was -0.5, which is a difference of about 0.6 diopters. While in a SMILE patient, at 1 week, it was -0.04 diopters, and at 9 months, 0.2, which was a difference of 0.16, which is a significantly difference between the 2 eyes in terms of stability. As regards efficacy, we again found that the SMILE eyes scored much better as compared to femto-LASIK eyes. And regarding induction of aberrations, because that was a concern for many people, because you are not able to do a customized ablation, people thought that you would not be able to get the same amount of aberrations or you would be inducing more aberrations. What we need to understand is that this is a different procedure altogether. Here, we are not using photoablation. Excimer laser suffers from peripheral fluence losses, and that's because it's falling as an oval in the periphery of the lens that we create. Here you are cutting out a lenticule, and therefore you can make it as you want, at whatever depth you want. And this leads to the minimal increase in spherical aberration. And therefore, and this is not shown by only one study, but a number of studies done world over, which showed that the induction of less than 0.12 microns of spherical aberration happens when you use SMILE instead of LASIK. This is also part of that same study where we compared the point spread function, and you can see that the SMILE eyes have much better point spread function as compared to the femto-LASIK eye. So is the image simulation. As you can see, the SMILE eyes definitely show a better image as compared to a femto-LASIK eye. And you can see that the SMILE eyes have a true zone of whatever you have destined to create. So if you wanted a 6 millimeter zone, it was giving you a pure 6 millimeter zone, unlike in an Excimer laser, as you can see here, where you would have the periphery getting lost in the zone of smoothing or a transition zone, and therefore the results are more stable, and you can also compromise on the zone size slightly, and you would still get away without any night vision issues. As regards the long-term data, SMILE shows remarkable efficacy, safety, predictability at 5 years. But now we are also doing studies at 10 years, and it's really showing the same things getting reflected. Other advantages are quite stark. There is no flap, so no displacements, less dry eyes because it's a smaller incision, less damage to the nerve fibers and earlier regeneration. Better patient workflow because you are not going to be changing the bed or the laser stations. And it's an easier sell for patients who want a flap-free, blade-free procedure. So it's truly a pain-free, blade-free, flap-free procedure. You can do up to -10 diopters of sphere and -5 diopters of cylinder, but myopia or myopic astigmatism less than -12.5 diopters of spherical equivalent. And this is, of course, the highest margin. As we know that ICLs, IPCLs are really giving us great results, as Dr. Sonu already pointed out. So you don't really need to treat on the cornea higher myopia than this. The total thickness of the cornea after lenticule extraction, what I go as the lowest limit is at least 375 microns, which means that if I've made a cap of 100 microns, I still leave at least 275 microns on the bed, and I don't really surpass that limit because we don't really have good ways to determine whether the biomechanical stability remains good after any refractive procedure done on the cornea. We still don't have hyperopic treatment or mixed-stage treatment possibility commercially, but it's on the way. We've already treated a few hyperopic patients, about 100, and the results are similar, if not better than femto-LASIK in these cases, with the advantages of not needing to create a flap. If there are other ocular conditions like cataract, glaucoma, of course, you don't want to do anything on the cornea and no corneal refractive surgery. If the cornea is very thin, somewhere where I would not want to do even a PRK, I would not really go ahead and do a SMILE procedure. People who have uncontrolled diabetes, diabetic retinopathy, severe dry eyes still remain a contraindication. So SMILE is a technique which has come of age. It shows across several studies remarkable accuracy, stability, safety, comparable and sometimes even superior to femto-LASIK. And in the next decade, it is likely to become the technique of choice to treat refractive errors. So all of you young ophthalmologists there, please go ahead and also incorporate this into your myopia or refractive practice, because this is definitely going to be a useful addition in your practice. All of you are most welcome to come and visit me in my Vadodara center. And we also train people. So if you need, you are most welcome to ask for help. Thank you very much.